I'd like to welcome everybody to today's webinar titled Physician Reporting and Billing Changes for 2019. My name is Scott Mash, and as always, I'm joined by my good friend, Miss Cathy Costello. With that, I'm going to turn it over to Miss Cathy.
Thanks, Scott. Hi, everyone. Thanks so much for joining us. This is going to be, I'd say, fasten your seatbelts because if you look at this particular slide, you'll see what we're talking about. When this rule was proposed, there were actually 3 separate rules that included the information that ended up in the final rule. And the original rule was the physician fee schedule, which had just tons of stuff in it. And we're going to look at that in a minute. But there was a separate ACO rule. And there was actually a holdover from last year, an interim final rule where CMS was still commenting and deciding what to do for hardship exceptions and a few other things. So when the final came out, it would seem like we waited forever for it, and it didn't make it into print until the beginning of November. The reality is that they combined all these rules into one enormous rule. And what we saw in it is, let me show you here. Well, I'm going to move ahead for 1 second. What this huge rule that came down on the physician side, because as you know, the hospital regulations are handled separately, this rule, basically, the 3 biggest focus areas were to simplify technology reporting. We knew that was coming because that was already in the hospital rule, which had been finalized earlier in the year. Huge section on restructuring Medicare payments, and we'll go into that in a lot more detail. But the third area and a priority area for CMS is patients' access to medical records. And when we look at the technology that physician practices will need to have and other practices within the healthcare continuum, this is going to be a priority area for all of them. So before we dig into the regulations, though, let's do a short look back on where we are at this point in time based upon the messages, what we learned, the lessons learned from 2017. And as you know, 2017 was the first year of the QPP, or Quality Payment Program, and represented a shift in how CMS was handling all their various programs, kind of combine them all under one umbrella. That what they did, because it was a new way of reporting for everyone, they made the thresholds so terribly low. I mean, incredibly low. I think we were at 3 points for 2017 would avoid penalty. And 3 points was you submit one of anything and you don't have a penalty. And you'll be interested to see this article. I think Cathy Rich actually is attaching it as part of the handouts, but this came out within the past week, kind of summarizing what happened in 2017. And basically, well over 90% of all the providers met that 3% threshold. And so 93% actually earned some type of bonus. And another only 5% actually earned a penalty. And I am going to guess that the other 2% are those that voluntarily submitted but weren't eligible for any type of bonus. As you know, the bonuses were not large. Although when this program had been planned, the idea was that you might earn as much as 14%. Definitely CMS had talked up at least 10% for being an exceptional performer. The reality was that everyone buckled down and did a really good job at reporting. There were so many high performers that the actual amount that was paid as a bonus was about 1%, and then an additional 1% or so, maybe a little bit more than 1%, for being an exceptional performer if you scored 70 or more points. We feel, as we're looking at what's going on in 2018 and definitely going on to 2019, that these thresholds are going to increase. You're going to add new areas that you're being judged on, like cost, and that this is going to change the mix of how people get paid,
and
definitely.
With those bonus points going away, it's going to be harder to be a high performer going forward.
Oh, yeah, absolutely. So we'll point that out as we go along. Places where there's changes that are going to impact people, but like every other payment program within the federal government where there's a bonus attached, it has to be budget neutral. And so that's why, as fewer and fewer people fall into that upper category, there's going to be a difference in the amount that's available for distribution, and that the incentive should be greater. What these regs do not have is, with all the things that they did put into it, CMS still has not released the final reg for an overall national plan for interoperability. And for those of you that followed the regulations from one year to the next, this was issued last year as TEFCA, which it was the plan to do an interoperable network across the whole country. And there have been many, many, many holdups on that, not the least of which is privacy and security. But our understanding is that something is supposed to be released on that within the next few months. The other thing that is not in the regulation is that final information blocking reg. We had looked at that 2 years ago and it went into great detail at that time. There was a whole section of regulation around information blocking, and this would affect how you make information available to other providers, but also how you make it available to the patient. And so everyone was assuming, based upon what was being heard, that about 6 to 9 months ago there was going to be a final rule out in this area. It is still not out. It is supposed to be in final review right now. There is a CMS annual meeting this week on Thursday and Friday, so it is quite possible that that rule might actually be released during that meeting. And so if that is the case, we have our hospital webinar, I think it's Monday, December 10th, and we definitely will include a section on the information blocking if that regulation comes out. The third area that does not appear in these regulations and was basically peeled out of the proposed regulations are the final structure for ACO reporting going forward. And although part of the ACO regulations were finalized within the rule that we're going to be talking about, it was what I would call the routine annual updates for ACOs. You know, what quality measures are going to be reported, were there changes in technology, you know, stuff like that. But the proposed reg had quite a bit in it about new structure for ACO and risk bearing. We're going to talk about that this Friday in the APM webinar, and so we're not going to go into that in depth now. But those are the three areas that we thought might have been in these regs that were not, and that will probably show up in the next couple months. Okay, refresher course is, since you all haven't lived and breathed this enough over the past year and a half, but you do have the two tracks. You have MIPS, which is basically still a fee-for-service model, and you have the APMs, the alternative payment models. And either one of those is going to garner you meeting the minimum requirement to avoid penalty from CMS for reporting, because they're looking for reporting about quality, reporting about technology, and a few other areas. Right.
Yeah.
But I mean, those are the two big things:
Yep.
quality and technology. And both sides of this equation do that. It's just how you report is different. Again, a reminder that it's really important as it becomes more difficult to meet thresholds that you do push your providers on to do that, because this is payment year 2021, it's performance year 2019. And for that, your providers, if they meet MIPS, will be eligible for up to a 7% adjustment. But we know for a fact if they don't meet the minimum requirements, that they will receive a 7% penalty. So really important to keep that in mind. This goes up to 9% in 2020. So you want to keep your eye on what is required as far as minimum reporting. And as always, if you are in an advanced alternative payment model, and again, we'll go into this on Friday, but you have a different form of bonus, and that is a lump sum bonus at 5%. So what's the difference here? And this is one thing I know we got asked an awful lot about in 2017 and 2018, is people were concerned about who they had to be responsible for reporting as part of MIPS. And originally it was physicians, it was physician's assistant, nurse practitioners. It was a much smaller group, and every year this is being expanded. And this year's going into 2019. The list is now expanded to include physical therapists, occupational therapists, speech language pathologists, audiologists, interesting clinical psychologists, and registered dietitians. Now, the reality is that many of these providers are not going to have the basic. Scott in the next slide is going to be talking about what is considered minimum, and who gets excluded for low volume for Medicare reporting. So a lot of these areas as ancillary types of providers are most likely, if you were concerned about them as individuals, are going to exclude out as low volume.
Many of them were finding they don't even have an NPI number because they don't bill it themselves.
Right. And once again, the whole thing about QPP, and for those of you who are either strictly technical or strictly, workflow people, is going to make you rip your hair out. But the reality is, behind all these regulations is the finance side. You have to understand how your organization bills. Who is considered to be a billable provider, and what TIN do they bill under? All of this goes into your organization in deciding who you have to report to for in a given year. Fortunately, CMS has really stepped up their game in helping you to identify those providers through the QPP website, which Scott will talk some more about later. But the reality is you want to check on that yourself so you make sure that that information is accurate. But in this group, I especially would pay attention to the clinical psychologists, because this is an area that is really becoming so important. And you'll see this in the regs as we go down when we talk about changes in substance abuse reporting and stuff, that behavioral health is taking a much more major role in healthcare generally. And when you look at the reporting, which is driven by changes in healthcare, you'll see that it also changes what you report. So make sure you're aware of clinical psychologists that bill in your organization as independent, have their own billing NPI and stuff. And if that is the case and you're doing individual reporting, you want to be looking to see if you need to report for them. And if you're doing group reporting, these are all folks that you can put into your group and have covered by the group reporting, and you do not have to worry individually. If you are reporting individually for any of these people and they are not excluded out for low volume, they will automatically be excluded from your promoting interoperability, which is the old meaningful use reporting, unless you choose to report for them. So it's just one way that CMS is trying to recognize that some of these providers may not ever have been subject to checking all the boxes and stuff that were required for meaningful use, for ACI, and now for promoting interoperability. But if you are reporting as part of the larger group, you just have them absorbed into the group reporting. Okay, I'm going to turn it over to Scott to talk about low volume and some of the other technical areas.
All right, so for low volume, and consider this with these, especially around those new provider types, you are only going to be included in the MIPS program if you bill more than $90,000 in allowed charges, you have more than 200 unique Medicare beneficiaries, and CMS just added this third category. You must also provide more than 200 covered professional services. So to be in MIPS, you have to meet all three. If you don't meet one, you're excluded. You can, if you're a provider who doesn't meet all three, let's say you meet one, you meet two, your scores are really good, you can opt in to MIPS. This is an explicit opt-in. You'll need to go through the QPP portal and say, yeah, I opt into MIPS. But keep in mind, when you opt in, you're opting in for that 1 year, and you are also then subject to penalties. You're in the bucket for the improvement or the increase, but you're also saying, I'm confident and I know that I'm subject to penalty as well.
Right, and just make sure when Scott says penalties, that means if you choose to opt in, there is no deciding later in the year that you don't want to participate. Right. If you check the opt-in box and you do not report, you will be penalized 7%.
And you can opt in any time during the performance year, so you have right up until the last day of the year to opt in. Now, if you choose not to opt in, but you still want to submit information, you can do that. It's called a voluntary submission. You're not subject to a penalty, but you're also not going to get an increase. We're going to talk a little bit more about that later, because anything you submit is subject to sharing on Physician Compare, and we've got a nice section on Physician Compare. So now I'm going to flip it. You are excluded from MIPS if you do not meet any of those exclusion categories, or if it's your first year in Medicare, or if you're in an APM, or you're participating in an advanced APM and you're determined to be a QP. You don't necessarily have to report to MIPS. Now, you can check your eligibility through the QPP portal. If you look for the participation lookup, it'll tell you, one, if you're included or excluded in MIPS, but also if you're a QP as well. I always recommend that if you have a login to the QPP portal, you go through there and you check the group eligibility tool. It gives you a little bit more information. It shows you where you are with respect to those dollar figures and those unique patient numbers. Also gives you a little bit more detail on all of your connected physicians and their APM status. So again, we want to talk a little bit more here about opting in. And again, the only reason you would want to opt in is if you know you are a high performer and you're going to have a score above 75. Other than that, probably not worth it, because if you're excluded for any of the measures, you probably aren't going to see a lot of financial gain there anyway. But anyway, your status is determined through 2 look-back periods. Effectively, you're going back 2 governmental fiscal years to determine if you're necessary, or if you're included or excluded from MIPS. And if you are excluded for either one of those look-back periods for any one of the 3 categories, then you're excluded. It won't change. You won't be excluded in the first and then somehow get included in the second look-back period. Once you're excluded, period. If you're again, you can voluntarily submit, but to be at any time, if you want to opt in, again, you have to meet at least one of the 3 categories of 90,000, 200 services, or 200 unique patients.
Yeah, and it's worth noting too that the opting in process also includes group opt-in.
Right.
Now, most groups are going to exceed the thresholds as a group, so you don't really get into that issue. But if you have providers who are maybe ineligible due to volume or something, but together you want to report for the group and you want to earn that group bonus, then they are going to be included and you don't have to go through the opt-in process separately. This is really the process that you use if you're doing individual reporting and the individual provider is opted out.
Also, if you are determined to be a facility-based provider, you're going to be automatically opted in and receive that facility-based score. There's no opt-in required. We're going to talk a little bit more about facilities-based scoring later. Cathy's got a great section on that later here in the webinar. All right, so now let's talk about how do you get to your final score. Really, the only change we see from 2017 and 2018 is the addition of cost. Cost comes in at 15% of your final MIPS score. The only category that goes down is quality at 45%.
Yeah, that goes up from 10% in 2018 to the 15% in 2019, because CMS was just warming you up this year on the concept of cost. And I'm sure you all, anybody who's paid attention to the reports that CMS has put out for you, have taken several deep gulps as you try to interpret all the cost reporting that they're putting out. But just recognize that they are going to, at some point, cap the cost as part of your formula. But for right now, you really need to start paying attention to that. Just from the aspect of understanding what it is that they are judging you on.
And that cost category has changed. We're going to talk more about that here in a few slides. So again, as a reminder, your performance period, the 2019 performance period is January 1 to the end of December. You have to use a 2015 CERT EHR. The costing and quality categories, those are full year. Your improvement activities and promoting interoperability are a minimum of 90 days. You can go a full year on those. You can go 91 days, but it's a minimum of 90 days. And also remember, anything you submit for 2019 must be submitted by the end of March 2020, and then the increase, decrease, penalty, improvement, whatever, will be applied in 2021 based on your MIPS final score. So another look at that. Again, you have your defined performance period being the 2019 calendar year. Submission, they're probably going to open the portal around January 2nd, seems to be January 2nd, 3rd, right around in there. You have until March 31st of 2020 to complete your submission. I always recommend earlier is better. Get those submissions done. But the date for submission via claims and via the web interface, they're a little bit different. We don't have a lot of folks using that method. And quite honestly, CMS is trying to do away with both of those. I think that's our long-term goal.
Yeah, and just a little sub-note on that is for those of you who still have providers doing Medicaid, the Medicaid timeline is always going to be a little bit different. We just spoke with Medicaid yesterday, and right now they are still in that January through March timeline, but they anticipate that it will be extended. So each year you have to look at that date separately.
So after your submission, probably sometime in April, you'll get what they call the preliminary feedback, which really is just a restating of everything you submitted. Then in July, you get your final feedback report. Those will be available through the QPP portal. CMS has let it be known that they're going to include more information. Because if you remember, when you got your performance feedback report this year, what was on your report, that's all you got. And there wasn't a lot of depth, especially around cost information or how they were doing, your list of attributed patients. You really couldn't see anything. CMS has stated that they are going to make additional information available with those feedback reports. They're saying something like the QRUR. We're hoping that at least it has attributed patients and a breakdown of how the cost category was scored and the components within that cost category. And then again, based on the information that's available in your performance feedback report, the adjustment up or down will be applied starting January 1st, 2021 to all of your fee-for-service charges. The one thing CMS did state throughout the rule is that you can use different submission methods for the different categories. You don't have to use the same submission method for all the components. Of course, costs, they calculate that for you automatically. You can submit PI one method, your quality another method, and your improvement activities by a third method, and they're going to put it all together for you in the same bucket. Now, if you do submit information via two different methods, the best one here to say is claims, then whatever method gives you the highest score will be used. So let's say you're a small practice, you're still submitting via claims, but at the end of the year, you also submit your ECQMs. Whatever would give you the highest score, that's what they're going to use.
Yeah, and what we've seen with some small practices is that they may have been attaching G codes to their claims, and so they may be coding for A1Cs, they may be coding for blood pressure, whatever. And then at the end of the year, as we work with them and they do EHR reporting through ECQMs, they may have exactly the same metrics that is being reported. And so you don't get dinged for that. You may have two sets of A1C reports, but as Scott emphasized, the same report reported in two different ways, CMS will use the higher or the more valuable score for you.
Right, and that is not down to the individual measure level. It's if your ECQM method is better than your claims method overall, that's what they're going to use. It's not, they're not getting down into the individual components within quality. All right, so now we're going to shift. We're going to talk now about that quality category. If you're in a group and you have 15 or more providers in your group, you are automatically going to have a 7th quality measure added to your final performance feedback report. You probably won't see this until the final report, but your readmissions now are your 7th quality measure. Now, CMS has a huge focus on readmissions. I think, quite honestly, every reporting program that they have, hospital, inpatient, outpatient, and the post-acute,
everything.
Yeah, so if
everyone's readmission.
Yeah, so if your readmissions are bad, get your hands around that, develop a program, because you're going to get dinged 5 times for your readmissions.
Yeah, and even if you're not in the hospital setting, you're still going to be attributed patients, and it may only be a handful of patients, but their figures as far as how many of them get readmitted will be attributed to you. And so you want to understand that attribution of readmissions so you understand what follow-up you can do to prevent that.
Right, very important. Also, the data completeness moves up to 60%. So remember now, when you're submitting your ECQMs back under PQRS, it was just your Medicare patients. Now you have to submit quality on 60% of all your patients, regardless of payer. Most EHRs submit 100% anyway. Your quality improvement bonus is going to be calculated the same in 2019 as it's going to be here in 2018, with one exception, that the minimum score or the floor for calculating improvement will be 30% of quality. So let's say this year you get last year you had a 10% in quality. They're going to bump that up to 30, and if you get an 80% this year, they're going to use the difference between 30 and 80, not the 10, to calculate your improvement. Topped-out measures. CMS is focusing very, very heavy on topped-out measures. These are going to be going away. Extremely topped-out measures are going to go away very quickly, but if you select a report on a topped-out measure, the maximum score you can receive is 7 points for that topped-out measure. Now, one thing CMS did do this year, they added some measures, they got rid of some measures, and they've tweaked quite a few as well. CMS has a goal through what they call the Meaningful Measures Initiative to eliminate most of the process measures in future years, and they did a large part of that this year with the elimination of 26 measures. We're quickly going to look at the 26 measures that were removed. This is just kind of the first block. The reason I wanted to at least bring them up is we have quite a few sites that use the IVD, use of aspirin or another platelet going away in 2019. The comprehensive foot exam also going away, worth pointing out. Quite a few here. Also, we have quite a few sites here that use the CMS 65 hypertension improvement, blood pressure. That's going away in 2019.
Yeah, and some of the reason, definitely topping out is the reason why a lot of those measures are removed. But the other reason is that there was quite a bit of duplication amongst the measures where they only changed by a little bit. And those of you who do quality reporting, you know what I'm saying. And so that's why you see, for example, their discussion around removing that hypertension measure was just that. They said that they were going to revert to using the less than 140/90 blood pressure under control. And they said the two measures are so similar that they felt more providers would be reporting on the blood pressure under control than the improvement. And so a bunch of these go to that. So if there's a measure you were using, look to see if there is a similar measure that you could fall back on so you have the same workflow.
Well, CMS did add some measures. These are the new measures, and I think it's worth pointing out that even though CMS has a huge focus on eliminating process measures, you're going to see 4 process measures on this list. Again, the details are available for all of these measures on the CMS website, or if these are ones that you're kind of looking at and you would like more information but can't find it, email Cathy and me. We will make sure that you get the information around that measure. All right, now we're going to transition over to cost. Keep in mind, this year, 2018, cost is 10%. For 2019, it goes up to 15%. You have no submission. This is all calculated through claims. Now, that 15% or your cost category is going to be comprised of 3 components in 2019. In 2018, it was total per capita cost and the Medicare spending for beneficiary. This year, they throw in some episodes. Now, keep in mind your total per capita cost. That's kind of a primary care cost category. The MSBP is kind of your acute or inpatient costs. The 8 episodes, you must meet a minimum of 10 episodes for the procedural based or 20 for the acute inpatient medical condition based episodes for them to be included. Out of these 8 episodes, it's not an all or nothing. You may have 1 episode where you're hitting the threshold. You may have 4, you may have all 8, but they will only be included if you meet the case threshold. So let's say you don't meet the case threshold for any of the cost categories, which would be in a small group or an individual provider. That's a possibility. Then your cost category will be weighted to 0, which means your quality will go back up to 60%. Really, that's what they're going to do, is go back to the 2017 scoring if you don't meet. Now, if you meet any one of the 3 categories, including any of those 8 within the episode or 2, then those components will be used to calculate your cost score. Let's take a quick look at the 8 new episodes. You have 5 procedural and 3 acute inpatient medical condition. And again, if you meet any one or more of these, then those will be used in addition to total cost of care and the spending per beneficiary to calculate your cost score. All right, improvement activities. A few tweaks within improvement activities. The biggest one is that use of CERT bonus goes away. That was the 10% bonus you got back to the ACI category if you select an improvement activity that was using the EHR. They're eliminating that bonus. You got to really focus now on your ACI category, because that was a 10% bonus. It was pretty big. The weighting of improvement activities has not changed. It's still 15%. CMS did give us 6 new activities. They modified another 5. The only one that went away this year was the participation in population health research. Take a quick look at those new activities. You're going to see the eye exam, comprehensive eye exam, financial navigation program, which, a lot of focus on costs, some collaborative care training, patient medication risk education, and then, of course, you're going to see opioid a lot through this. There was a new opioid quality measure. We have a new opioid improvement activity as well. Okay, there's been a lot of tweaks to the final scoring. So we just kind of want to summarize everything right here. You have to score at least 30 points to avoid penalty. If you want to be an exceptional performer, you now have to exceed a final score of 75 points or greater. That's up 5 points from last year where you only had to get a 70. The complex patient bonus, which can be up to 5 points, is going to be added to your MIPS final score. Again, that complex patient bonus looks at your dual eligibles, your high-risk patients. Probably they say the average score will be a 2.5 to a 3.7, could be as high as 5. The small practice bonus in the past and for 2018 is applied to the final score. In 2019, that bonus goes to the quality category, and it will only be applied to the quality category if the small practice or individual provider submits at least one quality measure. So if you submit no quality, you don't get the bonus at all. The highest quality score is going to be used. Again, that's if you're submitting multiple methods, or if you're in that facility-based scoring, which Cathy is going to talk more about here real soon. Wherever you get the highest score, that's what they're going to use. Also, again, just to restate that the bonus for the use of technology through an improvement activity, that bonus goes away as well. So now I'm going to turn it over to Cathy. She's going to talk more about some of these special scoring cases.
Okay, thanks, Scott. The facility-based scoring, this was a really interesting category because we had talked about this a year ago when CMS had originally proposed it for 2018. And what we're talking about here are those really, really difficult providers to report on. And I know many of you spent a lot of time holding your head and shaking it when you had to figure out how to report for CRNAs or pathologists or radiologists or whatever, because you're so limited in what's available as far as quality metrics. If they are not consistently patient-facing, you may have problems with even drawing ACI reports for them, which is now promoting interoperability. There were just a whole lot of problems around it, finding improvement activities that fit their particular practice. So CMS had proposed a year ago to take this group of what they were called facility-based providers, which are providers that basically bill in the inpatient, the ED, and they expanded it to include outpatient services attached to the hospital, so like radiology or something. They looked at it and they said, how could we, rather than having to report separately for these providers, how could we take the fact that they are already located in the hospital? And so to a large degree, they drive the hospital's quality reporting. Can we, in fact, include them under the hospital reporting umbrella and not have to have separate reporting? So CMS spent a lot of time discussing this, but hadn't quite worked out all the technicalities. So they pushed it off until this last round of rules, which will go into effect next year. And they did adopt facility-based scoring. So basically what this is a process where you are going to have, or the provider is going to have the option whether to be included in the QPP program in MIPS, or whether just to rely completely on the facility-based scoring, which is the hospital score. And in what Scott had mentioned earlier in the opt-in procedure, facility-based is different, and it's different than the way that CMS had originally proposed it. Because back when they had proposed it, each one of those facility-based providers would have to go in and attest that they wanted to be included under the hospital's reporting and not under the MIPS reporting. And you can imagine what a nightmare that is. So what CMS did is they flipped it around in the final rule, and everyone who was considered facility-based, given these standards, there's 75% of their Medicare Part B billing is in place of service 21, 22, or 23, inpatient, ED, outpatient. If 75% or more of their billing falls in that category, then CMS is automatically going to assume that they will be covered by the hospital's quality reporting. And we're going to look at the hospital quality reporting in just 1 second. So the nice thing about this is, for those of you who had a separate tax ID for your hospital providers, and you really struggled to get them reported and the quality reported for them, you will not have to worry about that this coming year. They will automatically be covered by your hospital's reporting unless you choose to include them in MIPS reporting.
And that's such a huge weight off the shoulders of those that have those hospital physicians. We've got a lot of clients that had to use a third party to do the extract and the reporting, and it's going to save a lot of money.
Yeah, and I mean, obviously, if you bill under one tax ID, and some of you do, you have one large tax ID for all your providers, then they're already subsumed into your MIPS reporting. And the way that this works is that if you do nothing else for them, they will be considered to be successfully reported. If you report for them under MIPS, then the cost and quality scoring will be attributed to them at the higher level, whether it's the hospital score or whether it's the MIPS score. And the one thing worth noting, though, is if you are submitting this facility-based scoring or facility-based providers in a MIPS scoring, and you decide to go ahead and do a group reporting for them, please note that you will have to meet all the MIPS requirements. So you will be including them in the ACI group reporting and in the quality reporting, but you will still have to do improvement activities for the group. And as I said, do your reporting for meaningful use, ACI, promoting interoperability.
And there will be some groups that, if they are technically all hospital-based, the group could be exempt from PI as well and only have to report on improvement activities.
Right.
And that's why we always say check that QPP group eligibility tool, because it'll tell you.
Yeah, it gets kind of different when you're in the hospital setting. But note that the rules say that if you're reporting these providers individually, or you don't even have to do anything to report them, you do not have to report improvement activities or PI. So basically, if you do nothing for them and don't include them in any reporting, they are considered successfully reported. And the only caveat I would have, and this is a major one for those of you who have providers who move from one facility to another, I call them itinerant providers. You know, if they work as ED physicians providing care as part of a group in different small hospitals, you have to make sure that it's your tax ID that has them covered, because it's the hospital where the majority of their billing occurs. And so that's the one thing I would check, is if they are billing under your tax ID, that it is linked within the QPP system as being the identified facility for reporting purposes.
And just one other thing here to note, that, you know, while the facility-based scoring alone meets the reporting requirement, if you want to go, you know, if your scores are very good and you want to be deemed a high performer, facility-based scoring in and of itself won't get you there. You've got to do that, at least the improvement activity, if you're excluded from PI as a group.
Right. And then just so you understand, because what we have found, there are so many CMS categories now of reporting and bonuses and, you know, improvement and all this other stuff, that a lot of times, if you're in a larger organization, and even if you aren't, if you're in a smaller organization, people don't always understand how those programs flow together. And so this is just one slide so that you understand when we're saying that the physician would be included under the hospital's umbrella for reporting, these are the metrics that go into what is called the hospital's value-based purchasing score. So VBP, value-based purchasing score, and CMS looks at how you perform in quality, safety, cost, and patient satisfaction. All gets rolled into one total performance score, the same way that the MIPS has a total performance score, the hospital gets scored a total performance score. So when we say that the physician will have either be attributed the hospital's performance score or the MIPS if you decide to do it, these are the measures we're talking about, where you're talking about the mortality, you're talking about very specific quality and safety metrics, the cost of the hospitalization, and the CAPS survey, the patient satisfaction survey. And so if you need any more information, you can certainly talk to your hospital quality people because they handle this area. Okay, now let's talk about promoting interoperability, because this is what had been meaningful use and for the past 2 years was called ACI, is now going to be called promoting interoperability. And what this is taking the measures and really contracting the measures into just a few categories of what you will be reporting. The other thing that CMS did about this, and this was based off of feedback from thousands of providers, what they'd done, I think it was 2 years ago when they put ACI in place, there was a different set of metrics for the hospital and the physicians. And so if you remember back in 2017, if you worked in a hospital system, you might have 3 different sets of metrics, Medicare, Medicaid, and hospital, that you needed to report on.
Chaos.
It was chaos. It really was. And consequently, a lot of reports didn't get filed because people thought they were doing it and just didn't get all 3 of them filed. But the reality is CMS is bringing it back together, simplifying it. So when we speak of the Promoting Interoperability program, it is taking CMS's biggest priorities, combining them into more simple measures, and then using those same measures for both the hospital and physicians. Now, the scoring is handled a little bit differently, but the measures are going to be exactly the same. So the measures that you will be working with in 2019 are privacy and security, always privacy and security. You don't get scored on it, but it's a prerequisite to reporting. E-prescribing, health information exchange, patient access to their records, and public health reporting. So these are the 5 big categories that CMS is concerned about. Please note, for those of you who are still doing Medicaid reporting, the state has the option whether to adopt this new stripped-down version of measures or to stay with the classic, what I call classic meaningful use, stage 3 measures. And again, I don't think that Medicaid has made that decision, whether they would move into the new Promoting Interoperability or not. But if that's something they do decide to do, we'll certainly let you know.
Yeah, we're talking to them about it, trying to encourage them to move to that. But we'll, as we find out more, we'll let everyone know.
Okay, here are the measures, and here is how they score. The basic breakdown with lots of little changes, but as I said, no points. You're working with a scoring of 100 points. And on the physician ambulatory provider side, whatever you score is factored into your MIPS score. You don't have to meet like a minimum number of points in order to attest. The hospitals, that's a little bit different. As I said, the hospitals are handled differently in this, although the measures are the same. The hospitals do have a minimum score they need to meet. But this is all performance-based. I'm going to go with the easier ones first, and then we'll end up with the ones where there's still a lot of conflict about what it was that CMS was saying. Public health reporting. That's a pretty easy one, basic one. You still will need to do 2 public health reporting measures. You do not have to do immunization if you are a specialist, but you do have to do 2 out of this category. You can do data registry reporting, public health registry reporting, immunization, syndromic surveillance, and electronic lab, although electronic lab reporting is not normally done in the physician space. And actually, syndromic surveillance usually isn't unless it's an urgent care center. But CMS did say in these rules that if the state accepts syndromic surveillance from a non-hospital setting, that you can report on it and it will meet the requirement.
Yeah, and we've not heard if ODH is going to continue with their current policy that allows for syndromic from non-urgent care, but we definitely are going to have that discussion with them.
Right. So I'm of the remaining 3, none of them are easy as far as not having changes, so we'll just dig right in. On e-prescribing.
Oh, Lord, we've had a discussion about this.
I can't tell you the 50 pages or so that were devoted to e-prescribing, how many times Scott and I have read this and argued about it.
Debated. Right up until the beginning of this webinar, we were debating it.
And honestly, because it's not clear, we sent up to CMS last week saying, hey, this is where we think it's unclear. How are you interpreting this? And the response we've gotten back is that, hey, this is a really good question. We can't answer it, so we're pushing it up to basically the people who wrote the rule. And so those people who actually have been quite helpful in explaining stuff haven't gotten back to us yet, but we will share that with you as soon as we have it. And now with all that preface, I'll tell you where we think the issue is. E-prescribing is going to include now 3 parts starting in 2019. It's going to be your basic e-prescribing measure. It's going to be a bonus for doing what in Ohio is called ORS checking, where you have to check every time you write a controlled substance prescription to see if the person has a history of getting the prescriptions and, basically are they prescription shopping. And then this third area called verify opioid treatment agreements. Let's take it the third one. The verify opioid treatment agreement is already pushed off until 2021. The technology is not there. What we're talking about here is for people who have are in substance abuse treatment. A lot of providers are using these opioid treatment agreements that basically we must have gathered 25 or 30 of them to look to see what they look like, and they're all pretty much the same. The patient will check anywhere from 10 to 20 different sentences about what they agree to do, and they'll initial that they are agreeing to that, and then the provider signs it and dates it, and it's kind of a compact between them as to how the patient is going to manage their recovery. And what these rules wanted providers to do is to go out and look for that in cases where they check the ORS database and see that the person has had 30 or more days of controlled substance prescriptions in a 6-month period, to go and look for those treatment agreements. The problem with the proposal is this was never done electronically. None of these are done electronically. And so CMS is like, okay, we recognize that you can't really query for them, so we're not going to require it. What we instead are going to say, we'll look at it again in a year and a half and see how the technology has moved ahead. But the ORS search, I think everyone in the state knows how to do that. Everyone is doing it. Ohio is much more advanced than a lot of states.
And for you technically to get credit for the patient to appear in the numerator for that measure, the query has to be performed before the script is written.
Right, right. And as far as the technology around it, CMS originally didn't want to give you credit for it unless the ORS query was totally integrated within your EHR system. And in the final rule, they backed off of that and said whatever the state accepts. In our state, they have web-based query. They have, what's the NARCS check?
NARCS check.
And the night before query.
The past RX.
Past RX query. All of those would be acceptable, but you will have to report a numerator and denominator. If you are able to report on that in 2019, you get 5 bonus points onto your scoring. Now,
one other point on that, sorry, is CMS will allow for a manual calculation of the numerator and denominator for that bonus measure, and they stated that they are going to release information later or early in 2019 around the documentation you would have to keep on hand and how you would calculate that manually. Sorry.
Right. The problem with ERX, now that we've told you the 2 parts that are new, is when you look back at the original e-prescribing measure, it gives you the option of whether to report controlled substances or not. And they did not change the way that measure is written, but the whole discussion in the rules is around adopting EPCS, e-prescribing of controlled substances. And so the question in 2019 is, are you required to have at least 1 patient with e-prescribing of controlled substances in order to be able to report e-prescribing, or do you have to take the exclusion? Because you can take an exclusion in 2019 if you're not prepared to do EPCS. And that's where the whole issue is. And as soon as we have clarification around that, we will let you know. So whether or not you can do general e-prescribing as you've always done, if you are not including controlled substances, or whether you have to include controlled substances to report on e-prescribing. So either way, when you're doing promoting interoperability, you need to have some type of value in each one of the categories if it's only 1 patient. Okay? Patient access, you lose the view, download, and transmit. You do not have to do that. You do not have to do secure messaging. What you do have to do is to make sure that information is pushing to the portal, and that is what patient access means under new promoting interoperability. As part of that, you also need to offer what's called an API, which is an app to allow the patient to access their information electronically. This is going to be a vendor issue for you. You have to find out what your vendor is doing and if they are offering an app or if they have a protocol around which a patient needs to get it. And so I think that's an important issue for you to take back if you don't know the answer to that, and you can follow up on it. As far as the patient app, what I think you want to do is, this is the language of the measure, so that they have provided timely access and it's available for any app of their choice. So you don't need to offer the app, but if the patient comes to you to hook up electronically, you need to know what the process is. And so you want to talk to your vendor about patient identity verification when they use an app, what security requirements might be, and what your policy is to allow for that app to be connected to your system.
But clearly, if you as an organization deem the app as being dangerous or at risk for a HIPAA violation, you do not have to allow it to connect.
Right. Okay. This question of coding and billing is just an enormous part of the change in the regs. And I don't know, for those of you who might have seen it, there was a proposal, or not a proposal, but a release this morning of a report by CMS about ways that they were responding to problems that providers had pointed out that they had in working with CMS. And this is one of the most major areas, is the coding and billing. because it's seen as antiquated. It's been 30 years plus since there's been an update in coding and billing, and the reality is that the coding and billing has not kept up with the technology. And so what used to be having to be done manually, and then you had to manually produce that for the payer when they wanted to audit you, can now all be done electronically. And yet, because you're working under old guidelines, you may be doing basically cutting and pasting and doing the same thing, which is not allowed. As you know, if you've been audited on it, you cannot cut and paste in a patient's record to produce the same information. So you end up documenting again and again and again the same information. So CMS is trying to respond to that and make the coding and billing guidelines more streamlined and more responsive to what is being done in the electronic health record. But before we get to those changes, I do have to point out, and we will go into this more in the hospital section, that one of the biggest things that was done, and this was in the hospital rule, is that if you were in a hospital-owned practice and you have been billing for physician office visits, a facility fee, that over the next 2 years, that facility fee is going to go away. What CMS showed with probably 15 pages of statistics is that a hospital billing situation for the exact same office visit, physician office visit, is being billed on the average 60% higher than the independent physician in the same community. And so what they're doing is taking that 60% and deleting it over a 2-year period, and just starting in 2019, 2020. 2020 you'll lose the second half of that. You will be billing just the same E&M coding for all physicians under the physician office visit. As far as the other coding and billing changes, let's look at this. The way that providers are used to looking at their billing is you have 5 levels of coding for CPT codes for E&M visits, and 1 being the simplest, 5 being the most complex. CMS had proposed to leave the level 1 and the simplest billing the same, but to collapse 2 through 5 into 1 billing code. And there were many, many complaints about that because physicians were concerned that the most complex patients that they were not going to be able to be reimbursed for the complexity of the case. So the final rule is a compromise, and it maintains level 1, takes levels 2, 3, and 4 and combines it, and then keeps level 5 as the most complex case, and the billing is separate. However, what CMS has done, I'm going to just flip over here so you can see it, is part of the coding is they say, okay, you can have your basic code under this level 2, 3, and 4, but you can attach a G code to represent the complexity of that patient's case. And there's going to be a primary care complexity code, a specialty care complexity code, an extended visit code, which is a time-based coding, and a prolonged services code.
So simplicity through G codes.
Yeah, and this is kind of crazy, but when we explained it all to a site, they said, well, so all they're doing is, changing around the billing, because the reality is this is the phrase, or this what CMS said in the regs. I mean, straight out of the regs. I had to copy it because I couldn't believe it. They said, we would expect that most practitioners enrolled in primary care would be billing the primary visit complexity add-on with every office outpatient visit. The visits would still need to be medically reasonable and necessary, and you'd have to document the medical necessity, but that the coding is appropriate for all cases. And so basically what they're saying is, I'm sorry to keep flipping back and forth, but under this new proposal where CMS would pay $90 for an established patient visit in this code, that they'd expect to see that add-on and take the value up to $103. So that's something to keep in mind, that when you look at this, CMS, because there was so much controversy around this, is not adopting this for 2019 or 2020. It will come into play January 1st of 2021. So please watch for this so you get educated around the use of these new codes. Because the other thing that you want to look at is another purpose of these regs was to update and recognize new technology. And for as many years as I can remember since email came about, there's been an argument about whether payers should have to pay physicians to respond to patients via email. And this rule is finally getting caught up with that and recognizing that there are times when a provider can talk to a patient through email or text or patient portal, and that constitutes a type of visit that is separate from telehealth, because as you know, telehealth has its own restrictions about when it can be used. But this is called, CMS has dubbed this the virtual check-in. And it's a 5 to 10-minute visit by a billable provider. It pays less than a face-to-face visit. It's a RVU of 0.25, and it's called a brief communication technology-based service, or G2012 coding. They specifically call out the use of this for opiate treatment check-in, but it's not limited to that. They just give that as an example. Another form of the electronic change in billing is they're calling an interprofessional consult, which allows both the primary care and the specialist to be reimbursed for a consultation that occurs without a patient's face-to-face visit with a specialist. The third place where the electronic consult is going to come into play in the billing is when a patient records something and sends it to the provider so that the provider can review it electronically. And this may be done like dermatology, if you take a picture of a mole or something like that, or ophthalmology, that this is now going to be a recognized way that could be documented and paid for.
I do think it's also worth mentioning that you do have to have verbal consent from the patient, because there is a copay.
Right. So yes, keep in mind that these new electronic coding all require physician consent, and it can be documented verbally. It's something that you could document as part of the electronic connection, but however you do it, it needs to appear in the patient's record. Okay. Turn it back over to Scott to wrap up a few things.
I'm going to buzz through these last sections because I just received a text from Ms. Rich saying we got a lot of questions. So we're going to buzz right through. A couple things we don't want you to forget for 2019 and 2020. The first being the appropriate use criteria, that it is optional in 2019 and you can receive extra credit through improvement activities. It becomes mandatory in 2020, though in 2020, they are still going to pay for claims whether or not the codes are attached. They couldn't bump it back any further than 2020, but really with the eliminate, since it's a test year, they kind of gave us another free year in 2020. AUC is excluded. You do not need to use it in the inpatient setting. In the emergency department for emergent patients, and the CMS language around emergent patients is that it's not required in the ED where an emergency medical condition is expected but not yet confirmed, such as severe pain or severe allergy. Also, if you have filed for a hardship, you're excluded, and technically where CAH style billing, the billing method is used, it's excluded as well. It is required in physician offices, hospital outpatient, the ED for non-emergent, and they also added ambulatory surgery centers and independent diagnostic testing facilities. They have not changed their priority areas. It's pretty much the high dollar diagnostic imaging where you've got to run the CDS rules or the appropriate use criteria. One thing they did specify in this rule is that the ordering provider doesn't necessarily need to be the one who runs through the AUC, but it is their responsibility to ensure that it does get ran and that the information does get passed to the performing provider. The furnishing or performing provider does have the option of consulting the AUC, but it does not count for the ordering provider in that specific example. Physician compare is becoming more and more important. This has been around for a while. What it is just a website that's been designed by CMS where you can go and you can query different providers, see their score, see their star rating. We want you to keep in mind that any data that you submit through MIPS or an APM is subject to appear on Physician Compare if it meets several criteria. It's been risk adjusted, it's complete, it's blah, blah, blah. It can appear on Physician Compare. This includes information submitted by providers who either opt in or voluntarily submit. If you do voluntarily submit data, you can actually have that excluded from Physician Compare during a short period. But all of your quality measures can appear either on the dashboard or through the downloadable database. You're not going to see costs for another year or so, but we really think it's important. The reason we bring this up is when you're setting your strategy for reporting, consider what is going to be available for viewing. And a specific example is, last year we had a lot of folks that submitted additional measures to maximize their bonus points in the quality category. Now you got to think about it. I mean, because if you have high scores on those additional high priority measures, then yeah, you want to submit them. But then if you start to get down into that third decile or a 0 decile measure, it may not be worth submitting that to get an additional bonus point if that measure is going to appear on Physician Compare. So just really think about your strategy for submission, painting the best picture of yourself, because it's going to become more and more apparent. Okay, and the last area is just recognize that the rule is populated with new things that involve treatment of opiate and substance abuse. So you just want to keep an eye on that. We won't run through them all right now. And the one thing that we had skipped over that I do want to go back to before we start the questions is under promoting interoperability. The health information exchange measure is broken into the two parts. The one that you're familiar with, which is sending stuff out electronically, which still maintains an exclusion for 100 or fewer transitions of care during a reporting period, but you also have that second part where information is flowing into your system and you're supposed to take it into your system and reconcile your medications as you put it into the patient's record. And there is an exclusion for that second one if there's a technology issue for this year. All right, so now what we're going to do here, I've heard we've got a lot of questions, Cathy. Oh, geez. So give me just a second to get these pulled up. So I want to make sure I got my window real big so I can read them real easy. He made me promise that I wouldn't have laryngitis today. That's how I didn't have to do them. Okay, if our laboratory system is only 2014 ONC certified, will we not be able to submit for 2019? I assume what you are talking about is the lab system at the hospital. That is traditionally not taken into account when you're considering reporting or testing. So as long as the reporting system is 2015 edition cert, you should be fine. Yeah, there were a few lab systems that got certified for ELR reporting, and that's really not I think you're okay even if it's not 2014 certified. All right, for 2019 reporting for EPs, if you take an EHR upgrade, can you report with a mix of the two versions?
Not in 2019. 2018 you could, and a lot of people are doing that this year because they did not have all the patches and the upgrades that were going to put them into a full 2015 edition cert. So you need to make sure that your vendor has totally implemented you on 2015 edition. You only need to have it for 90 days, and it does not have to be effective January 1st. So if you're going to report October 1st through the end of the year, then you need to make sure that that's in place, by the end of September.
All right, quality improvement bonus is for the same submission type, correct? Let's say 2018 we submitted CMS web interface, and then 2019 we do ECQMs. Does this qualify? I would say yes, it does, because what they're doing is they're looking at your final quality score between the 2 years and then calculating from that final quality score the improvement. So yes, you would still have the ability to receive that improvement bonus. If a provider's practice in an inpatient setting, do we report the inpatient PI data as their MIPS PI data?
Now, I'm going to assume that you're talking about the ones that you would not be doing facility-based scoring around. So if your system is a unified system and you can report on that physician's information as it pertains to e-prescribing and stuff, that's great. If it's within the hospital system, it would depend on the coding. If it's an inpatient visit, it goes into the hospital's reporting. And that's, always been one of the issues around using meaningful use for physicians who practice inpatient.
Yeah, and the QPP's participation check will tell you if that provider is excluded. Hospital-based and excluded from PI.
Because a lot of times those are, your place of service kind of dictates whether you're going to be using that information as part of their reporting.
All right, next question. This is on the facility scoring, Cathy. We have a non-physician providers who are part of our ACO and MIPS reporting. QPP shows them under the hospital 10, so we can exempt the group from PI and only process improvement activities.
Okay, if they're exempt, the whole group, I'm wondering, are you talking about the whole group or individually? Because individually, you probably are going to exclude most of them.
Yeah, they're in an ACO, so I'll bet we're talking group level reporting.
Okay.
Actually, if they are in an ACO, then you would not have to do any quality reporting under MIPS.
Right.
They would, if they are hospital-based, then they should be exempt from promoting interoperability, and actually you don't even have to do improvement activities when you're in an ACO.
Correct.
You're covered by the ACO.
Correct. Yeah.
So you should have, in that specific case, no MIPS reporting to do.
Correct.
Okay. For group ERX reporting, do all providers have to be able to ERX controlled substances, or can only a subset of the group?
Okay, this is an excellent point, and one that we've talked about any number of times with groups as they try to implement this. The new promoting interoperability is performance-based and not threshold. And so the requirement to report is, other than privacy and security that is required for everyone, is that in each one of the categories you need to have one patient or you have to be eligible for an exclusion. And so the reality is, when you're looking at adopting EPCS, you do not have to have every single provider who writes controlled substances working under EPCS, as long as you have some of your providers meeting it. It just means that your performance is going to be lower because you're going to have more prescriptions in your denominator and fewer of them meeting the e-prescribing. But the reality is you can do it piecemeal, and that's what I like about this new approach. Is it recognizes that you don't always implement, especially if you're working with a larger group, you don't implement everyone at the same time on every single functionality. So if you're doing group reporting and you've got 50 providers who do controlled substances e-prescribing and you only have gotten 10 of them onto EPCS, you can still report successfully.
Next question is with regards to API. Who makes the decision to whether an app is too dangerous, the organization or the EHR? And I would say it would be either. If you hear about an app through, let's say somebody writes an app to access Allscripts, but Allscripts says, hey, we don't recommend you use that app, then I would nix it. Also, if the vendor says this app's okay, but for whatever reason you guys deem it as too dangerous, then nix it.
Yeah, and what we have been telling the hospital systems, and to a smaller degree, I would say the exact same thing for a practice, is write down your process. Write down exactly how you're going to handle this app situation, who's going to make that decision, and what the criteria are. And it's not saying that you should be particularly technical, but if you have some issue and you've checked it out and you're not comfortable with it, you have that right to say that you are not going to have them connect. But you have to have criteria about why you are not allowing them to connect.
Okay, next question. Patients will not expect to be billed for phone calls or texts or portal use. There may be backlash from them. Further, the doctor won't determine if it's long enough of a phone call or email thread to bill until it's over. And the MD to MD consultation may be over phone. How they get patient permission prior to that. You know, really, we throw that out there as that we want to make you aware of those new codes. There may be ways that you can work the billing of those new codes into your workflow. So let's say through your portal, when a patient gets ready to submit a message, you may say, hey, by submitting this message, you are authorizing us to bill and recognize that you may be billed a copay. There are ways to do it. Cathy and I think that this is going to take a little bit longer to kind of iron out, but just kind of keep that in mind.
Yeah, these codes are going to be available for 2019, but the reality is there's a whole lot that's going to have to go into actually making them workable. And so you do watch for that training from CMS, but think about how you could possibly incorporate that billing.
Okay, with many systems continuing to grow and independent clinicians utilizing large organizations, EHRs, so many consulting providers have access to EMRs of patients being transitioned to their care. Has the measure of support electronic referral loops by sending electronic information changed in 2019? No, the sending hasn't changed at all.
Right. So if they have access, you can always exclude out providers who are part of the same system using the same EHR. That depends on how you decide to report. You just have to be consistent with how you interpret that.
Second part to that question, can eligible clinicians receive points or bonus points for electronic transmission of summary of care records to non-eligible clinicians like nursing homes? Absolutely. You can include those transitions to nursing homes, home health, any non-EC provider caring for your patient.
You just have to make sure that you either have an email or some avenue of sending that out to them electronically.
If my doc orders an ultrasound of kidney and it's done outside his practice, why does he need to add AUC code to the chart since he doesn't bill? There's a little code that's going to be generated by the AUC to demonstrate that you ran through the process, and that needs to follow the order to the performing provider who then drops it to the bill. If I switch EHRs in the second quarter, how do I report for that year?
You only have to report a 90-day period. And so what I'd suggest is it depends on, one, is your old system 2015 edition certified? If it is not, then you are going to be required to make your 90 days after the adoption of the new system. But since it's only 90 days, you can certainly get your workflow going and report for later in the year.
Yeah, you probably, in this case, unless you use like a registry or something, you wouldn't be able to report your quality. You could try to report out of the new system.
It depends on if you have 60% as your threshold.
If you switch EHRs earlier in the year, you could probably submit less than a year quality and be okay. But either way, if you just submit your promoting interoperability, your improvement activities, and then your costs are calculated for you, you're going to avoid penalty even without submitting quality. And I think that's the key point.
Correct, because you don't have to, it's not an all or nothing proposition.
All right, quality reporting, or quality improvement. I reported in 2017 In 2018, I belonged to an AAPM that did not report to MIPS. If I leave the AAPM in 2019, how will they judge my quality improvement for 2019?
They won't be able to. They have to have a year-to-year figure to compare.
If AUC is submitted as an improvement activity for MIPS in 2019, what other requirements are there to get the bonus points? Must I submit to, if you're using the AUC improvement activity, that's the only requirement to get those bonus points. Well, wait a minute, that goes away in 2019. You don't get the bonus points back to the or promoting interoperability. So the use of AUC would fulfill one of your improvement activities.
Improvement activity.
Yeah, the bonus goes away.
But it is an improvement activity.
Absolutely.
So you get the points for that.
We buzzed through those questions quick, Kathy. That's our last question.
Okay. All right. Well, we thank you all so much. We know it ran long, but, hopefully it was helpful. We will let everyone know when we get a response from CMS about the EPCS and whether you take an exclusion or you can report e-prescribing without having EPCS implemented for any of your providers.
Thank you all so much.